Each one of us could figure here. The photograph is not of the doctor. That's the best part. That's of the reporter. She wanted her photograph there. First is Indian Express, second is Hindu, and the third in Times of India. AIIMS suspends 5 doctors after a nurse dies in the post-delivery area. Our own nurse, Mrs. Kaur, our own employee, she dies because of a seizure, during a seizure in my hospital. The bottom line is that it happens. No matter what you take care, these kind of things will happen and will be blown in the newspapers because we live in an era of sensational journalism. And look what kind of a comment we got. This is the top comment. So many patients died due to doctors, nurses' negligence, and no one is suspended just because one of their own colleagues has died. Therefore, so much of action. Please have the same rules for each patient. Read more. If we conducted an inquiry, we suspended somebody, then again we are at fault. And mind you, we are one of the largest state-of-the-art public teaching hospital in our country. And I don't know, for the last 15 years, we always come as #1 as a teaching public hospital in our country. So we suspended people because a patient died after an emergency cesarean who was our own colleague. Now we have a lab named after her. We've done enough of damage control. But the fact is that the Delhi Medical Council, as a suo motu action, suspended 2 of those guys. And again, sadly enough, one of them is my postgraduate. He's left anesthesia, mind you. So these things do happen. We come back to the topic. An emergency cesarean section, which is a life-threatening obstetric emergency, would depend upon the competency of the staff, the nurses, the opticians, and the anesthetist. It is not only the opticians and the anesthetists, or it is not only the anesthetists and the opticians. So once you have a category 1 or once you want to give a GA for whatever reasons to these patients, have you realized that GAs have become rare for cesareans? It is next to impossible to get a new fellow in England or Australia or New Zealand who is given a GA for a cesarean section. The place I used to work was, if you even think of a GA, call your consultant. And when the consultant comes, he tubes the patient, he doesn't let the resident do it. So the skill of giving GA for a cesarean section, emergency or non-emergency, is on the wane. That's how the simulation comes into it. But what is important here is that you plan it, and all of you are aware of it. How do you plan it? This is basic anesthesia teaching. And if you don't say all this in your exam, you will not pass a diploma or a degree exam in anesthesia. But in spite of this, things again happen. And there are few things which are new. I'll come to that. The choice of laryngoscope is changing world over. It has been envisaged that a video laryngoscope is always a better bet than to change over from a normal laryngoscope. If you work in a system where you have a video laryngoscope, it's always better to use a video laryngoscope. And we are ourselves carrying out certain simulation studies on high fidelity simulation as video laryngoscope to be the first laryngoscope for the resident to be taught laryngoscopy and intubation. It will take about 2 years to come out, whether we right or wrong. But the fact is, it has been accepted that the chances of the first time intubation are more if you are using a video laryngoscope. The studies may be biased. You will get a Cochrane review next year, I'm sure. I don't know whether it's coming or not. We'll say more studies are required. All Cochrane reviews give you this kind of statements. But if you have one, start using them. I was a bit apprehensive, but now I have also followed the bandwagon. It works. It is surely easier. You see where you're putting it, and then you have an assistant who's seeing what is he doing. So these things have come in. The choice of laryngoscope is yours, and then it's the standard thing. How do you pre-oxygenate is this thing. But the fact is that you've got to take care of these. And this is where we fail. Monitoring and documentation, we fail. That's why we'll end up into problems. We talk about all the things in the exams, all the things in our lectures, but when it comes to brass tacks, we are found deficient in both of these. Then there's something known as a rapid sequence panel. You all are aware of it. It's a standard thing. But what is important is, and it is slightly difficult in India to have it, where everybody is chewing pan or supari inside the OT also. Many of our ORAs and whatever. How can you have somebody without a mask coming into the theater? They are all logistical issues, but this is a known entity. You can give a spinal which is fast, you can give a rapid sequence spinal, and what is important is that you don't wait for the level to come up at the level of T4 or T5. Once the level is ascending, you have a level of T10, then you can really proceed, and all that is done after you've talked to the patient. And this is the next important thing. All airways for emergency cesareans, no matter what it was when you saw the patient, are difficult. We tend to forget it because the older we get in anesthesia, we become confident. The more confident we become, we're going to have a bigger accident. It's only the anesthetist who feels very proud of the fact that I work alone in the theater for 18 hours. Have you seen a surgeon working alone? Even if he gets a postgraduate, after some time, postgraduate gets a third-year student gets an intern. And we are very fond of working alone and when we land up into a mess, we are totally gone. So if you are stuck up in a case, if you think there is a potential of problem, call somebody, get somebody along with you, and then you can manage that life-threatening emergency better. This is just about last week. This is come in last week, and you know they are talking about these three things. I've talked about the laryngoscope, the other is the supraglottic device. It is still a rescue device. It is still not acceptable as a standard device. Take it from me. If you use an LMA and somebody aspirates and dies, you will have a tough time convincing the judge that you were wrong. You were not wrong. Okay? But as a rescue device, you must have one up your sleeve. And now the teaching is that you should have two up your sleeve. And two up your sleeve would be the second degree ones, which have a channel for the esophagus. And what is coming in, like ultrasound comes in everywhere nowadays. Before you have your lunch in a conference and after you have a lunch in a conference, there will be an ultrasound now. And the organizers will charge you registration money according to that. Dr. Prabhakar is agreeing to that. And this is what is happening. Front of neck. This is the in thing nowadays in the developed countries because patients are obese. They are about 150 kg. So they want to mark the front of neck where you need to put a needle when you land up into a problem. You see the three colors, the yellow color, a slightly red color, and a yellow ochre color or orange color. The yellow color is the cricothyroid membrane. You need to put a needle there when you land up into a mess. And I also know that none of you have put a needle, if at all you have gotten into a mess. But the future is this, you're going to get more healthier patients, and the people who propagate it, they're going to talk about it, and this is no harm. If you think you're going to land up into a mess, even if you don't have an ultrasound, you could have the markings done and then induce a GA. What's the problem? Then the problem comes that I have never punctured a cricothyroid membrane. I know that. The only way to learn is you come to us, we'll teach you on a high fidelity simulation. You'll have to pay about 3,000 rupees for a workshop a day with some sandwiches and juice only, no lunches and dinner. Alternately, if you work in a ENT setup and somebody is going for a total laryngectomy, tell your surgeon, take him out for a beer, put a needle there and give a local anesthesia to the cricothyroid membrane. The larynx is going to come out anyway. I learnt it that way and my surgeon was very comfortable with me because the larynx was coming out anyway. Okay, but the controversy here is to use a scalpel or a needle. This is the latest controversy and it has been laid to rest because now they feel the scalpel is the in thing. If you land up into a mess, saturating at 82, patient is hypoxic, and mind you, you're working among, sorry, no hard feelings, among so many women in a labor room or a maternity OT. There's a chaos. It is better to use a scalpel because you have a bigger incision and you are able to put in a tube faster. If you do a needle cricothyrotomy, you are in a mess because you've got to give high pressures and barotraumas are much more. So this controversy has been laid to rest. And this is a quote which I have put. If you have done it earlier in the sheep larynx, goat larynx or a mannequin, you will be able to do it if you land up into a mess. We come to the second part. We all know that MOH is the leading cause of death all over the world. And this is the definition. The definition varies from place to place. It is basically has to deal with patient to patient. You've got to know that tachycardia and hypotension could be a physiological side effect of a pregnant mother. So once the BP goes 60, then the problem starts. So you got to take care of this. There are various definitions, but that's not important. Your patient clinically becomes important, and these are the main causes of the hemorrhage. This is again standard postgraduate teaching. This is equally important because at times it comes to us, how do we deal with it? The medical management is equally important. And we all do it, But the fact is that we've got to keep on hammering it. We've got to keep on hammering it to opticians. Well, I can't give a bolus for more than this. I can't give a bolus for more than this because there are issues involved. And then everybody uses it. Everybody of us uses it. So these are all to stay. This is the medical management, and this is the initial management of MOH. What is equally important is the one which I have encircled. We miss on that. We don't heat our fluids. We don't heat our blood products. We don't warm the patients, and hypothermia causes equally more important problems in these patients. Invest in a hypothermic device. If you can't invest in a fluid warmer, keep a 3,000 rupees made in China microwave oven in your labor room. Just put in a bottle. Hopefully your bottle will be plastic. Waste 5 bottles. This is what we have done. Wasted our pallets. Now we have our fluid warmer, cupboards. Everybody knew that you put it at high, put it 30 seconds, and 500 ml will become at this temperature. So you got to avoid it. And then you continue to monitor, and equally important is hemodynamics and fetal heart. Put in your invasive lines early. Mind you, when the BP is 60, you can't get an art line. But when the BP is 94, you can get an art line. Doesn't matter. Maybe 80 times, 90 times your art line will be not of use because your friend will say you're wasting money. But when you are in a mess, it will be of use. And then point of care things, viscoelastic, they're going to come in a big way, mind you. They're going to come in a big way because blood transfusions have been decreased for PPH and MOH after these point of care devices have been used. They are there with us. They may not be there with everybody. They would be there in a multi-centric hospital who has a transplant program. But once it comes into a transplant program, then it remains there, and then you can send your samples there. So you can exactly decide what to give at what time to give. Fluids and fluid blood products. We all know we don't have to give starches in septic shock, but we also don't give it when patient is hypotensive, not beyond a limit, and these are the recommendations. The recommendations were different. Then we looked up the data of Afghan soldiers of America, and we came up with a ratio of 1:1:1 regarding blood products, FFPs, platelets, and RBCs. It is now questioned that 1:1:1 is causing more problems, so you should have point of care devices, you should have a rotom or a TEG to do that, but India is still a bit behind that. But the fact is, as we stand today, if you give 1:1:1, if a patient has lost about 1.5 liters of blood, you are totally safe. And then, if you are a Bhuvan hospital, you could have a massive transfusion pack, you could have a massive transfusion policy, and mind you, it is not bad and it is not difficult to invest upon these kind of policies. You're going to have a lot of turnover if you work in a bigger hospital regarding your nurses and residents, so they can work very well. Again, this is not available everywhere. Well, we are lucky we have it. We have a cell saver. We used factor 7 sometimes, but now it is again going out of disrepute. Factor 7 in PPH was off the counter, off the label use. There were studies which showed a huge advantage, but now that's gone. And then surgical interventions and invasive radiology is there to stay. They have their own issues. It is beyond this time that I talk about them, but in bigger centers, you would have people who would be able to do that. This is the second part. We come third part, collapse. We all know this. I'm sure you'll have many workshops on this. You just need to know two things, that when a lady collapses who's a parturient, the life support is the same as everywhere else. The airway will be difficult. You must remember that. And two other things. Resuscitation has to have two modifications, a tilt and a chest compression at a higher site. And God bless you, if you're going to have an anti-mortem cesarean, you'll have to convince your obstetrician to do that. You'll have to convince your optician that the lady has collapsed to do that in the labor room, in the ward. I don't know whether she or he will do that or not. But that's what legally right, and if you don't do it, you're going to get stuck in the courts. Mind you, you're going to get stuck in the courts. And if your optician doesn't do it, please document it. Maybe he or she is not going to call you if you're on your own nursing homes again in your life. Maybe you'll have to leave your city and practice somewhere else, but still it is worthwhile to document it and save yourself from the court of law. This is the last slide here. I don't have time to talk about it, but we must remember that eclampsia and pre-eclampsia are also life-threatening obstetric complications. Each one of us is aware of it. Each one of us has managed it, and each one of us have our own ways to go about doing it. It is very easy to follow what is mentioned in the Western literature. I very well envisage that AIIMS New Delhi is not everywhere. To get a platelet count done in a city would mean 6 hours. You get a platelet count today and the patient comes for cesarean tomorrow and you can't, with a history of PET, and you can't repeat a platelet count. This is where your clinical acumen comes into picture, or this is where you have to practice safe medicine. In conclusion, maternal-driven emergencies are more difficult, but the best part is 99% times the outcome is good, but if a disaster occurs, it's a nightmare. You got to manage 2 patients. The mother scores over the baby, but mind you, every human being is different. It's something like let me have a ticket in the train, let me get a sitting position in a train, let me get a berth in a train, let me get a lower berth in a train, let me get into a 3-tier AC, 2-tier AC, and then we go on thinking. The person who said the mother is important first when you told them about the problem will sue you on the baby, mind you. So take care of those things, and I hope you take care of your mothers and you don't have accidents in your practice. Thank you.
Thank you, sir. This is question about jaundiced mother. Is it an emergency in cesarean or no cesarean?
So a jaundiced mother, it all depends, sir. It is again a chapter. I wish you give me another 35 minutes to talk about health syndrome and jaundice in pregnancy. I'm more than happy to speak extempore even after 5 minutes. Jaundice per se would not be a category 1 cesarean. If you talk about a patient who's 32 weeks and jaundice, and your obstetrician is trying to tell you that it's an emergent cesarean section, you've got to accept that. But jaundice per se is not emergency. It is not a life-threatening emergency. You see so many patients who have come to you with viral hepatitis for whatever reasons and have a bilirubin of, let's say, 14 with no fetal heart. Then it's not an emergency, it's an urgency. Many times they don't want to do a cesarean, they will induce labor and the dead fetus is expelled. But if the fetal heart is there, and if the fetus is mature enough, and the jaundice is increasing, yes, it becomes an emergent cesarean. But it doesn't become a category 1 cesarean. Category 1 cesarean, we talk about severe bradycardia, cord prolapse, where the cord is getting compressed and becomes non-pulsatile. And when at times we've seen that the patients are brought in with 2 fingers per vagina so that the cord has been pushed in. So that's what I said, sir. In your place in AIIMS in Bihar, Patna, make a categorize 1, 2, 3, 4 and get it documented every time. You just have to start it. Yes, sir. Dr. Gupta.
Yeah. As I said, this is not a question, this is just a comment. After a long time, I had a lovely session. All the 3 speakers were fantastic, and Anjan was superb, absolutely. I don't think that after this session there can be any question also. It was so much with the clarity and every component so versatile presentation. I congratulate all the 3 speakers.
Thank you, sir.
And the rest of the people who will be speaking in the future, they should take this as a role model speaking. Sir, can you pass?
Any more comments, sir? This one? Pradeep?
One line, sir. For pre-eclamptic toxemia patient going into emergency cesarean, I feel strongly that without fear, spinal anesthesia is a much, much better choice than general anesthesia. Because people always think there will be a sudden abrupt fall of blood pressure, which never happens because of excess circulating catecholamine.
So thank you, sir. I think this controversy has been laid to rest way back in 2006 or 5. Pre-eclamptic, coming for a seizure, spinal not to be given is buried in the ground.
Yes, exactly.
It is not a controversy anymore. So you can give your spinals, you be comfortable,
okay,
and it's acceptable. Now there is nothing about it.
Thank you, sir.
It was a topic of discussion in 2002 or 3 maybe in India. Nothing after that. Yes, ma'am.
So I'm Dr. Sajna from Columbia Shah Hospital, Bangalore. It's just a comment. Like, though we don't categorize the emergencies, the grade 1 emergencies, we have something called as code green. So it's like a code blue. So everything is activated within 5 minutes. Everyone is there in the labor room, OT for the surgery. And it's activated so quick. There's a suggestion that you can...
No, that's very fine. It is a commendable practice you have in a hospital, but my issue is only something else. If you try to do something which has not been validated world over, but it is practiced in the NHS, if you land up into a soup medico-legally, you are very clear. Our judiciary judges are very comfortable if you quote an NHS study. But if I quote your hospital, they will say which hospital. But you doing a commendable job, you could shift it to category 1, 2, 3, 4, and it is practiced in all the Commonwealth countries, mind you. Not only in England, not only NHS. So it's just like writing ASA 1, 2, 3, 4, you write category 1, 2, 3, 4, that's okay.
Sir, any papers on Dexmed use in preeclampsia, eclampsia cases?
See, I'll tell you, you can get away publishing anything in India. The MCI curriculum committee, I'm a part of it. Like a stupid fool, I stand in front of you and say that we have said 2 papers should be presented, whatever, before you give your MD exams. Dexmed has not been allowed by the Drug Controller of India to be used in pregnancy. Sir, you use it, God bless you. If you land up in the court, I will stand in front of you and prove that you are right. However, you get a lot of such articles from Turkey, East European countries, tremendous. But why do you want to use Dexmed? Tell me, what do you gain? People were using ketamine for labor analgesia. There was a paper from Maharashtra, I have seen that, and there were a couple of group of people who were doing it very well, and we applauded them because they had excellent results from Maharashtra. Ketamine as a labor analgesic. But the moment you go and present it in the world, they think we've come from, Andaman Nicobar, that tribe which has got banned. So my summation is, I am not aware of anything regarding Dexmed in pregnancy or labor or whatever. And my suggestion is, let's teach our students, let's practice what is allowed by law. That time when we didn't have ethical clearances, that time when we didn't have those 240 channels on the TV is gone. Anything you do can be blown apart in your city, at least in your language, by a cable TV. Who will ask you 10 lakh of rupees to stop that coming every hour? No, I'm not saying wrong. I have seen it happening. If you want to stop anything in the news, you got to pay. Sir, this is what the answer. I'm sorry if I have not satisfied you, but that's what it is.
Oh, thank you, Anjan. Thank you for your excellent presentation. The session comes to a close.
I requested Dr. Uma ma'am to give the moment to do, sir. Thank you, sir. Thank you, ma'am. There is a little announcement. Preliminary quiz, which is supposed to held in Hall A at 4:55 p.m. It's now will be held in Hall F.
बंद कर दो। हाँ नहीं वो मैंने साइलेंट बोला।
आपका सब अच्छा है ना? ठीक ठीक है, ठीक है।
Welcome again. Now we are going to start our next session, IV fluid and blood. For that, I would like to invite Dr. Uma Saxena ma'am, Professor and Head Department of FS Hospital, and Dr. Sukhdev Nayak, Professor and Head of Department of AIMS, Bhubaneswar. Kindly, sir and ma'am, come on the dais. Yes, sir. Welcome to our next chairperson, Dr. D.S. Gupta, sir.
So a very good afternoon to all of you. At the outset, I'd like to thank the organizers of ISACON 2018 for inviting me for this topic, massive blood transfusion, effect on pH, volume, and post-operative outcome. Now, exsanguination from trauma, massive gastrointestinal bleeding, and massive obstetric hemorrhage are the major cause of mortality throughout the world. Mortality is very high during first hour following bleeding in case of uncontrolled hemorrhage. This continued high mortality rate is attributable to ongoing hemorrhagic shock, which occur as a self-perpetuating triad of coagulopathy, acidosis, and hypothermia. So measures are undertaken. Resuscitation started with volume replacement, treatment of coagulopathy, hypothermia management, surgical control of bleeding. New resuscitation protocol, massive transfusion protocol, reduced mortality according to the recent literature. In 1970, it was 76, and it has come down to 40% now after implementation of this massive transfusion protocol. Now coming to the definition of massive blood transfusion. According to the World Health Organization, in adult, replacement of 1 blood volume or 10 units of blood or more in any 24-hour period, or transfusion of more than 4 units in 1 hour, or replacement of 50% of blood volume in 3 to 4 hours. In pediatrics, replacement of 100% of blood volume in 24 hours, or more than 50% of the blood volume in 3 hours. According to the NHS Foundation Trust, massive blood transfusion is defined as a transfusion of blood greater or equal to 150 ml per minute, or 100% of blood volume per 24 hour, or 50% of blood volume in 2 hours, where blood volume in case of adult is taken as 70 ml per kg. There are several definitions of massive blood transfusion in different books and literatures. Here is one important article. They have defined transfusion of more than or equal to 10 red blood cell unit of an average adult patient within 24 hours, or transfusion of 4 RBC unit in 1 hour with anticipation of continued need for blood product support, or replacement of 50% of total blood volume by blood products within 3 hours. So, they have introduced the concept of component therapy in the definition. This is another very recent article. According to them, a massive transfusion is defined as transfusion of 10 units of RBC in 24 hours. NICE has a different look into it. They have given a practical clinical definition of massive blood loss, which bring down systolic blood pressure of less than 90 millimeter of mercury or heart rate of more than 110 beats per minute. So, the most acceptable practical definition of massive blood transfusion in acute blood loss setting is transfusion of more than 4 units of packed red blood cells in 1 hour, or more than 10 units of packed red blood cells in 24 hours. Now, what are the indications of massive blood transfusion? Any acute ongoing blood loss with unstable hemodynamic is the indications, such as in severe trauma, massive obstetric hemorrhage, when blood loss is more than 1.5 liter, severe gastrointestinal bleeding, uncontrolled hemorrhage, major surgeries, ruptured aortic aneurysm, and some cases of transplant surgery. Now, there should be a standardized management protocol to manage this massive blood transfusion, that is called massive transfusion protocol. When to start or initiate transfusion? In severe trauma patient, there are several scoring systems: trauma associated severe hemorrhage score, assessment of blood consumption score, emergency transfusion score. These scoring systems are used for severe trauma patient to start or initiate massive transfusion protocol. In cases other than trauma, non-responders where systolic blood pressure is less than 90 millimeter of mercury post-resuscitation with 1 to 2 liters of intravenous crystalloids, or exsanguinating person needing life-saving surgeries. Now, according to NHS Foundation Trust, massive transfusion protocol will be applied when there is active bleeding patient in whom transfusion has started and needs to continue. Who will initiate? Senior resident surgery, anesthesiology, after consulting hematologist or transfusion specialist will activate massive transfusion protocol. Now, how to activate? Communication with the blood bank is very important. There should be adequate staffs to carry the blood packs, blood samples from the emergency department to the blood bank and from the blood bank to the OTs. Patient resuscitation will start with large bore intravenous access. 2 peripheral lines should be started with 14 to 16 IV cannula, and if peripheral lines are not available, then central line should be used. Adequate amount of crystalloid and colloid should be infused. Now, what is the adequate amount? According to the literature, in case of crystalloid, it is 1.5 to 2 liter. In case of colloid, it should be 1.1 to 1.5 liter. And what type of fluid should be infused? There are controversies whether normal saline or Ringer's lactate. But in early phases of trauma, both are safe. Resuscitation should be started with blood as early as possible to prevent the complications of massive blood transfusion. Rapid infusion pump or pressure bags should be used to speed up the fluid infusion. Invasive arterial line to record mean arterial pressure and core temperature monitoring is very important. Hypothermia should be prevented at any cost. Inline fluid warmers or surface warmers like Baer-Hegart devices can be used, and the blood samples are will be sent for baseline investigations for blood grouping, cross-matching, full blood count, coagulation screening, PT, INR and MPTT, fibrinogen, biochemistry, sodium, potassium, calcium and ABG. Every 30 to 60 minutes, again the blood sample should be sent for full blood count, coagulation screening, point of care testing by thromboelastography or rotational thromboelastometry is very important to assess the viscoelastic property of blood and to manage or to detect early trauma-induced coagulopathy. Ionized calcium and arterial blood gas also should be checked. Now, what type of blood should be used for massive transfusion protocol? O positive blood for all male patients and female patient not in reproductive age group, O negative blood for all female patient in reproductive age group, and O positive blood for female patient of reproductive age group if O negative is not available. Now, what will be the ratio? There are controversies throughout the world, which one is good. But PRBC and plasma pre-established ratio of 1:1 is mentioned in most of the literature. This is one article. They have stated that currently there are no definite worldwide accepted algorithm for blood transfusion and strategies for optimal coagulation management. There is increasing evidence that a higher ratio of plasma and RBC 1:1 endorsed by platelet transfusion might result in a superior survival of patient at risk for trauma-induced coagulopathy. Now, coming to the adjuncts of massive blood transfusion, tranexamic acid is the answer. It has been shown to improve survival in non-obstetric major trauma patient, and a follow-up analysis of CRASH-2 trial confirmed the benefit of tranexamic acid in hemorrhagic patient, severe hemorrhage patient. And another trial, the World Maternal Antifibrinolytic Trial, is a large multicentric trial currently investigating the safety and efficacy of tranexamic acid use in severe postpartum hemorrhage with good results. But tranexamic acid should be should be administered within 3 hours following bleeding, and the dose is 1 gram for 10 minutes bolus and then 1 gram every 6 to 8 hourly till bleeding is controlled. Here is some special situations. If there is prolongation of prothrombin time, ABO-compatible fresh frozen plasma in the dose of 15 ml per kg should be given. If APTT is prolonged, then factor VIII and fibrinogen concentrate is recommended along with fresh frozen plasma. If none is available, then 10 to 15 units of ABO-compatible cryoprecipitate is given. Regarding platelet concentrate prophylactic is not recommended, but it should be administered in cases of clinical signs of microvascular bleeding when platelet count is less than 50,000 per cubic millimeter. What is the end point of massive transfusion protocol? When hemoglobin will be 8 gram per dl, prothrombin time less than 18 seconds, APTT is less than 35 seconds, platelet more than 1 lakh, fibrinogen more than 1 milligram per dl, then massive transfusion protocol will be terminated. Who will decide this? Senior resident surgery, anesthesiology, and critical care specialist will take decisions. Now, coming to the adverse effects of massive blood transfusion. Mortality is very high in massive blood transfusion, and its etiology is multifactorial, mainly hypotension, acidosis, and coagulopathy. The lethal triad, that is acidosis, hypothermia, and coagulopathy, have the highest mortality rate, about more than 90%. Coming to effect on pH. First is the dangerous problem, metabolic acidosis. It occurs as a result of hypoperfusion, liver dysfunction, and storage lesion. Hypoperfusion will lead to lactic acid production. This lactic acid, if liver function is normal, is converted to glucose by Cori cycle. But in case of liver dysfunction or liver hypoperfusion, there will be lactic acidemia. Along with the storage lesion, that is increased acetate and pyruvate due to RBC glycolysis and falling of pH to less than 7, this will give rise to metabolic acidosis. Now, what is the effect of metabolic acidosis? So, inadequate resuscitation leads to hypoperfusion of tissues. There will be lactic acidosis, ultimately giving rise to systemic inflammatory response syndrome, disseminated intravascular coagulation, and multi-organ failure. Another effect, expression of thrombomodulin on endothelium. They form complexes with thrombin, so there is no available thrombin in the blood. Moreover, they will activate the protein C anticoagulant. These together affects coagulopathy. Both extrinsic and intrinsic pathways are affected. Hypoperfusion also leads to unmetabolized citrate because liver function is not normal, citrate is not metabolized. So, this excess citrate will chelate calcium and magnesium, producing hypocalcemia and hypomagnesemia, ultimately worsening metabolic acidosis. Coming to the role of bicarbonate in metabolic acidosis, usually it is not required, but bicarbonate therapy is reserved only for patients with severe metabolic acidosis when base excess is -7 milliequivalent per liter or more on ABG, and this should be corrected according to the formula mentioned. Coming to metabolic alkalosis, another problem. Metabolic alkalosis can occur due to citrate overload. This citrate will be converted to bicarbonate, and if kidney function is normal, this bicarbonate will be excreted to the kidney within 5 minutes. So, the effect of metabolic alkalosis will be transient, but if kidney function is not normal, then it will give rise to metabolic alkalosis, sorry. Now, this is a pictorial diagram how metabolic alkalosis occurs. Massive blood transfusion causes citrate overload, increased bicarbonate production. This excess bicarbonate will be excreted to the kidney, but if kidney function is not normal, in case of renal disease or inadequate resuscitation leading to hypoperfusion of kidney, then metabolic alkalosis will occur. The effect of metabolic alkalosis is it will shift oxygen dissociation curve to the left, so there will be decreased oxygen delivery to the tissue. Coming to effect on volume, inadequate resuscitation. Inadequate resuscitation causes hypoperfusion, lactic acidosis, sepsis, and multi-organ disease, multi-organ dysfunction. But what happens to overzealous resuscitation? There will be interstitial edema due to increased hydrostatic pressure and fall in colloidal osmotic pressure, ultimately leading to abdominal compartment syndrome. If it is not corrected in time, there will be hypoperfusion of kidney and abdominal organs. Ultimately, the complications of massive blood transfusion will be evident. Next problem is dilutional coagulopathy. Why this occurs? What is the etiology of dilutional coagulopathy? The etiology is not definitely known. In early phases of hemorrhagic shock, there will be shift of fluid from the interstitium into the blood. This will cause hemodilution. Another effect is if you give excess amount of crystalloid and colloid, this may also cause hemodilution. So, these are the causes of dilutional coagulopathy. Another important effect of volume is transfusion associated circulatory overload. Excessive crystalloid and colloid, when given very rapidly in case of underlying cardiac disease, renal disease, or chronic severe anemia, may give rise to this problem, that is transfusion associated circulatory overload. Now, citrate toxicity and hypocalcemia. This is also a problem of massive blood transfusion. This citrate will chelate calcium, and with hypothermia and acidosis, they will reduce cardiac output, produce bradycardia and dysrhythmia. Coming to post-operative outcome. This is related to the adverse effects of massive blood transfusion. First is early trauma-induced coagulopathy. It has multifactorial pathogenesis, probably due to crystalloid and probably due to crystalloid and RBC transfusion without plasma and platelet. There are other causes like hemodilution, thrombocytopenia, immune modulation by hyperfibrinolysis may also produce this early trauma-induced coagulopathy. But if it is associated with hypothermia and acidosis, the lethal triad of refractory coagulopathy will occur. Here is an article. They have stated that uncontrolled hemorrhage and subsequent massive resuscitation can result in development of coagulopathy, hypothermia, and acidemia in post-injury period. The etiology of coagulopathy is multifactorial and involves a combination of both dilutional and consumptive factors. The total volume of blood loss as well as blood component products used for resuscitation contributes to this lethal triad. Next problem is transfusion-related acute lung injury or TRALI. Transfusion-related acute lung injury is a clinical syndrome manifesting as hypoxia and bilateral non-cardiogenic pulmonary edema. The diagnosis is done by clinical symptoms and diffuse opacities in both lung field on X-ray. It occurs during 6 hours of post-transfusion. And usually, the patient will be treated in ITU and symptomatic therapy will be advised. Now, this is an article. They have stated that TRALI is now a second leading reported cause of mortality from transfusion and leading cause of transfusion-related death reported to US FDA. Metabolic complications, hypocalcemia and hypomagnesemia. Hyperkalemia is also a problem of massive blood transfusion if whole blood is transfused, because in whole blood there will be hemolysis of blood and that will produce hyperkalemia. So, fresh RBCs within 5 to 10 days old or irradiated RBCs or washed RBCs can be used to prevent this problem. Coming to hypothermia. Infusion of cold fluid, blood product and opening of the abdominal cavity or thoracic cavity during operation, this will produce heat loss. And under anesthesia, there will be decreased heat production. So, all this together will produce hypothermia. The effects are decreased citrate metabolism, acidosis, and they worsen also the coagulopathy. So, if hypothermia is associated with metabolic alkalosis and low 2,3 dpg of stored blood, they will shift oxygen dissociation curve to the left and there will be decreased oxygen delivery to the tissue. If hypothermia is associated with metabolic acidosis and hypocalcemia, there will be refractory coagulopathy. Now, this is an article. They have stated that rapid transfusion of multiple units of chilled blood may reduce core temperature abruptly and can lead to a cardiac arrhythmia. And 10 units of cold blood product and an hour of surgery can lead to 3 degrees centigrade drop in core temperature and hypothermic coagulopathy. Other complications are bacterial contaminations and septic shock may be due to transfusion-related immunomodulation or post-transfusion purpura when antibodies are directed against platelets, but recovery of platelets occur within 2 to 4 weeks, and it also can be treated by immunoglobulin infusion, steroid and plasma exchange. Another problem is transfusion-associated graft versus host disease. It's fatal, treatment is supportive, but it can be prevented by irradiated RBCs. Other problems are common to blood transfusion. Transfusion reaction, acute and delayed, they varies from mild arterial rash to anaphylaxis, maybe due to ABO incompatibility, mismatched blood transfusion, even small volume of blood, 5 to 10 ml, can cause a severe reaction. If detected, it should be documented and treated, and the blood units with transfusion set, fresh units, urine sample, blood samples should be sent to the blood transfusion center for investigation. And the patient may need renal dialysis So experts' help is needed and multidisciplinary approach is needed to treat the patient. So coming to the summary and recommendations. Management of massive transfusion is extremely challenging. Highly organized universal massive transfusion protocol is required with adequate staff and blood bank to have a better outcome. Hypothermia should be either avoided or minimized at any cost. Blood investigation along with point-of-care testing, that is thromboelastography and rotational thromboelastometry, detect coagulopathy at the earliest. Early transfusion with plasma, PRBC 1:1, has successful outcome preventing hypoperfusion and early trauma-induced coagulopathy. Organ perfusion to be maintained to prevent adverse effects of pH, volume, leading to a better postoperative outcome. Thank you.
Any questions from the audience? Questions, please? No.
I think people are getting tired. We are in the faggots of the day because this is one of the very critical issue in our practice, particularly those of us who are involved with the major surgeries.
Rachana wants to.
You want a question? Yes, please. Yes, please.
Ma'am, when we are giving unmatched blood, that is O negative blood, after that, once we can do ABO compatibility, what time should we give the matched blood? Means there are antibodies with O negative blood, and if we have to start the ABO compatible blood transfusion.
Yes, there is possibility. That is why massive transfusion protocol is implemented. First start with O negative blood, then send blood for grouping and cross matching, and then treat accordingly. Okay.
No, ma'am.
Then?
After giving O negative blood,
yes,
the O negative blood contains all antibodies, no?
Yes.
Means when can we start using the ABO compatible blood?
Usually it is after half an hour because half an hour is needed.
But those antibodies will be there for...
If you go through the massive transfusion protocol, they have mentioned that first start with ABO, that is O negative blood, and then you just take the blood samples. So adequate manpower should be there who will collect the blood samples from the emergency department to the blood bank. And then it is that for grouping and cross matching, is it a bit time consuming, at least half an hour is needed. So first start with O negative blood and then this proper grouped and cross matched blood should be transfused.
But then those antibodies of that O negative blood, they won't react with, if we are giving like positive blood, there has to be some time period till the time those antibodies, they are washed away and then we start giving ABO compatible blood, no?
But in the protocol they have not mentioned it. Because as you have to give more than 10 units of blood and you have to start the resuscitation immediately. So you have no time. You have to start O negative blood. You are bound to start, isn't it?
No, no, that is okay. That is acceptable that we are giving O negative blood for resuscitation.
Yes.
But after, do we need any gap or we can give, once the ABO compatibility report comes, we can start that blood?
Yes, we can start that blood. No problem.
Thank you, ma'am.
Good afternoon, ma'am. I'm a second year postgraduate student and I have some question pertaining to massive transfusion protocol.
Yes.
So, ma'am, we do a lot of trauma cases because we are near the highway, near our hospitals near the highway. So, whenever we give blood, at some point we are always told to give calcium gluconate because the blood preservative is always a chelating agent.
Yes, yes.
So, is there any protocol as to
yes,
when we are supposed to give calcium?
Yes, there is protocol. After 4 packs of blood transfusion, you should give 10% of 10 ml calcium gluconate. And if it is calcium chloride, half the amount, that is 2 to 5 ml.
So only after 4 units, we don't give it before that?
Yes, that is mentioned in the protocol. No doubt about that.
So we don't give it after 2 pints or 3 pints?
No,
we wait till
not
4
like
pints.
that, no.
No, if the liver is normal, then you don't need up to the 4 pints. You don't need. If the liver is good.
If you have no idea,
our first choice is always calcium chloride because that is in ionic form.
Yes. 90%
and it is available. The question is whether you kept it or not. Where it is not there, then we go for the gluconate, which is a non-ionic.
Okay, so we can wait for the 4 pints to get transfused and then check.
Yes.
Or otherwise, after 1 or 2 pints, can we confirm on an ABG and see an ionized calcium and then think about it?
As you have no idea about the liver function, usually after 4 packs this calcium is administered. But there is no need to administer calcium if liver function is normal. Because,
Okay, ma'am. Thank you.
In earlier part of our practice, I still remember when I was in the cardiac almost 30 years back, our calculation was 3 ml per pack of calcium.
Okay.
But then we started getting a lot of articles where they denied it. They said that if the liver is normal, liver function is normal, you don't need up first 3-4 pints. Because anything that you give, it has got its own reactions also. So we start, today's, it's absolutely founded that up to 4 units you need not touch your calcium, provided your liver is good.
So if you have deranged liver function, then
you can give it earlier.
Yes, in case of deranged liver function, this calcium, this citrate will not be converted to bicarbonate. There will be excess calcium, excess citrate, which will chelate calcium. Okay, the problem is here. But if liver function is normal, citrate is converted to bicarbonate, excess load will be excreted through the kidney.
Okay, thank you.
As simple as anything.
I'm Dr. Krishna Kumar from Chennai. During massive blood transfusion, when to start the platelets?
There are controversies. Usually in case of microvascular bleeding and when platelet count is less than 50,000 per cubic millimeter, platelets should be transfused. Otherwise, in other cases, platelets should not be transfused. But there are lots of controversies. You can go through the literature. You can see that even 1:1:1 ratio has been mentioned.
So we can do a platelet count and after that we can decide.
Yes.
Okay, thank you.
Regarding a substitution, I was just listening to you that you had mentioned about normal saline, Ringal lactate.
Yes, sir.
Today we do not prefer either. We prefer the acetate. Because the question acetate. Because as the lactate concern, in case of a massive transfusion or a big trauma, there is always a possibility of non-clearance of the lactates.
But
so
sir,
patient will develop lactic acidosis.
Yes, they have mentioned that initial phase of resuscitation in UAN can be used. But it is better, Ringer's acetate is better, no doubt.
Yeah, it's good. Yes. I think it's a very crystal clear presentation. Congratulations for lovely speaking, making the subject very clear to all of us, those who are listening carefully. So, do you want to speak anything? So,
it's one of the important topics, and with the increasing trauma, is very much important that this is a part of the CME topic, as there are a lot of interest by the young postgraduates, definitely, and it is very controversial because the pathophysiology, physiology is very complicated. A lot of other organs are also coming to the picture, so we must know where to give and what to give. Very, very important. Thank you very much for enlightening us. Thank you.
I request to our chairpersons to give the memento to ma'am.
Can you join? Yes.
Sir, please, Ashwa.
Our next speaker is Dr. Anirban Hom Chaudhary. He is a professor and ICU in charge of GIPM New Delhi. His areas of interest is mechanical ventilation, sepsis, research, ethical and legal medicines. He is the expert committee member of the MCI, National Board of Examiners, New Delhi, AIMS, New Delhi, Institute of Liver and Biliary Sciences, New Delhi, Kerala University of Health Sciences, Aligarh Muslim University, and Drug Control General of India. He has 38 publications to his credit. He is also a principal investigator in the ICMR and Department of Biotechnology. He has received 3 awards: Asian Congress of Pharmacoepidemiology, Hong Kong, Delhi Pradesh Bhagirath Samman 2014, and Honorable Excellence Critical Care Medicine 2016. And he will be speaking on another important topic, that is a rational approach to perioperative fluid therapy from physiology to improved outcome. So again, another important topic, mostly for the postgraduates. So over to Dr. Anivan.
Thank you, sir, for the kind words. At the very onset, I wish to thank the organizing team of ISACON 2018 for giving me this opportunity and bringing me here. And I know it is the fag end of the day, and it is difficult to keep everyone sitting and awake and alert. But at the same time, I think that I won't take too much of time. I will stick to whatever time has been given to me on this topic. Now, as we know that the fluids are indeed our saviors in all phases of life, although the situation, the context, and the timing makes a difference, and it is based upon that timing that the subsequent outcome follows. So therefore, the perioperative period is also no different from the remaining phases of the life. Probably we have a window to visualize this within a narrower spectrum. And we have plenty of fluids, and plenty of fluids have their plenty of prepositions, and the compositions are decided upon by the manufacturers based upon the understanding of the human physiology. Like as I said about the normal saline, nothing is normal about normal saline. All this, it is proudly proclaimed to be the most isotonic and matching. If you see the content of the sodium and chloride, and we know the effects of chloride on the kidney, so probably we would think that it is probably an abnormal saline. Likewise, lactated ringer is also there, but it is also certain deficiencies, and probably we are coming up in current generations with the use of plasma and balanced salt solutions, but as we understand, our concepts grow with time, the composition of the fluid also changes. So the choice of fluid is primarily dependent on the situation which arises or in the context on which it is being used, and subsequently it is changed, rephrased, reformulated, and taken back. It is de-resuscitation is as important as resuscitation, as we know. Therefore, the perioperative period usually involves an interplay of various complex factors. And if you see this graph, you will be able to appreciate that even before the surgery actually begins, there are a lot of things which shift the volume status. Like you give general anesthesia, which causes some vasodilation, so there is relative hypovolemia. So similarly, you do some procedures, doing a TURP, you irrigate with a lot of fluid, so you develop hypervolemia. So the procedures, the comorbidities, the bowel preparation, the preoperative hydration status to which the patient is exposed, particularly if someone goes rigorously and makes the patient dehydrated forcibly, so that also causes hypovolemia. So the curve is basically a U-shaped curve where, if you see, as we go for hypovolemia, all the risk of organ hypoperfusion, sepsis, multi-organ failure is high. As we bring down this to euvolemia, this morbidity goes down. And again, as we increase the volume and go towards the hypervolemia side, again, all the risk of morbidity becomes high. So essentially, we get a zone around which we have to keep the patient, and that is what is the biggest challenge in the perioperative period. By a simple calculation, I assume that there are some PG students who would be here, that you have to understand the composition of the body fluid for an average 60 kg per person, around with a 60% of the body weight. The distribution follows more or less a semi-calculative form, around 24 liters, 60% of 60. So like that, you can have and that ratio is again in the 2:1. When it comes to the extracellular volume, it is against 4:1. So you have an idea of the amount of distribution of the normal fluid composition when you choose that particular type of fluid. And you have to correlate with the fact that the composition of the electrolytes varies in these spaces, and the choice of fluid is primarily meant to match the composition of the electrolytes where they are likely to stay for long. So therefore, if we know that if we have to resuscitate and if we start using 5%, we will end up only administering 10% of the fluid into the intravascular volume where it is required most. In contrast, we're using ringer lactate where we actually more than 360 ml actually remains in the intravascular volume. So the need for fluid in the perioperative period has been cited as the first line of hemodynamic support. Why? Because it restores the volume, it enhances the perfusion pressure and sustains that so that the oxygenation improves, the cardiac output, the tissue blood flow and the oxygen delivery is maintained. And these changes are profoundly influenced by the cardiac and the peripheral vascular status, that is on the patient's preoperative, premorbid and the comorbid conditions. Therefore, the same fluid therapy can have profoundly different and even opposite effects in different states. And therefore, it is very important for us to realize that in which part of the Frank-Sterling curve is actually our patient when we are administering the fluids. As long as the patient is on the steep part of the curve, no matter how much fluid we induce, everything will be improving. But once the patient is in the plateau phase of the curve, it is probably the time to restrict fluids and in even advanced cases to try and de-resuscitate them, because that is the time where we are trying to reach that hypervolemia and all the side effects of fluid overload can actually manifest. So 3 concepts should be considered for the fluid and electrolyte management. One is the concept of the cell membrane permeability, second is the osmolarity, and third is the electroneutrality. In cell membrane permeability, the cell membrane is capable to allow certain substances to pass freely, the sodium and the water, and trapping others like the protein, like the albumin and etc. So this is the capability of the cell membrane which we should realize. The osmolarity is the property of the particles of the solute which decide the movement of the solvent. So if actually sodium chloride is present, it breaks down into Na plus and Cl minus. We have 2 osmotically active charged particles that is going to decide the shift of the water. And third is the electroneutrality, which means that if bicarbonate goes out, then equally there will be an effect on the chloride which will be retained by the kidneys to maintain that electrolyticity, and thereby there is a possibility of inducing a state of hyperchloremia. So on that basis, if we start, there is a big debate on crystalloids and colloids going over since the past 10 years, and the colloids are almost out from the ICUs. In ICUs, we never use any other colloids apart from albumin. But definitely in the OTs, in the perioperative period, the starch has been used. And if you ask me that whether to use crystalloids or colloids, it is probably the situation in which you are facing, then it is probably the best situation, is the time for the anesthetist to decide that which fluid he chooses over the other. Both have certain advantages, both have certain disadvantages. The studies, the success trial, the HES trial, but these were all in critical care setup, which have shown clearly that if you use HES, that is the starch containing solutions, the incidence of RRT increases, the patient's kidney dysfunction increases, although they have the composite outcome didn't change, including mortality. But still in the perioperative period, you can use starch, you can use any form of colloid which you think like, if your concern is to prevent hypervolemia and yet you intend to retain some amount of volume in the intravascular space so that the perfusion is not disturbed. If you see the commonly used intravenous fluids, you will realize that their composition and content is variable to an extent that can influence the state of metabolic acidosis or alkalosis to which the patients might get exposed during the transfer. And it is a continuous dynamic process, and there is no magic thumb rule on the basis of which you can pinpoint the exact amount. Your monitoring and your assessment should continue side by side. There is a calculation for maintenance intravenous fluid. We all know it. We have read it during our post-graduation days. But there are problems with this method for the reason that it can be applied to certain sections or beyond certain age. And for every 100 kilocalories expanded, a certain amount of fluid is lost either through insensible water loss or through renal function. A small amount is generated through oxidation of carbohydrates and tissue catabolism, which is ignored in the calculation and which can make the calculations fallacious. It doesn't take into consideration the caloric expenditure above maintenance or take into account the ongoing fluid losses. You need separate calculator or separate logarithmic approach for that. And a simplified or empiric application to the caloric method has not developed so far, which can promulgate an easier appreciation of all those changes that fit into a novel formula. If you just apply the thumb rule and you have a patient, a 60 kg of male undergoing APR who is NPO for 8 hours, the procedure is of 6 hours, the estimated blood loss is 1500 ml, and you calculate using your maintenance that by the 4:2:1 rule, and you calculate the deficit by maintenance into the hours of fasting, replace blood with a 3:1 ratio and calculate the third phase losses as per the given table, then you end up this patient giving 10 liters of crystalloids intraoperatively. But can you imagine the kind of damage you might induce if you don't monitor the status of the patient course-wise to prevent such a grossly hypervolemic state? We have to realize that the clearance of crystalloid during anesthesia and surgery is 10 to 20% of that in awake volunteers. Most of the studies that determine the dose of the PKPD studies which determine the dose of the fluids is based on volunteer studies, of course followed by clinical studies. So that dose becomes very important here. And the crystalloids leave the plasma space and equilibrates with the interstitial space after 20 to 30 minutes, which is a big time, during which time there can be a lot of hemodynamic disturbances due to the fluid shift if the patient loses blood during the surgery. Therefore, even this was reported way back in 1999, 13 patients who because of such a volume overload died from pulmonary edema because they received average 7 liters positive balance during the first 24 hours. 10 out of 13 were ASA1, average age was only 38 years. So that raises the concern of a restrictive approach over a liberal fluid therapy. Again, if you see this study, you will realize, whole study, the more the positive fluid balance, worse are the outcomes. But incidentally, when this study was conducted, it found that it is important to need to focus the effect of individualized and the goal-directed fluid administration rather than a strictly restrictive approach. So that again changed or swayed the concept because a purely restricted approach did not affect the outcome, the mortality. Therefore, a more directed or goal-directed fluid administration was important, and we had one trial which is called the optimized trial, and that trial didn't show any difference. We had a second trial going on whose reports are expected by January next year. That is the optimized 2 trial. Probably it will come up with some results which we will be able to translate into a better effect. Now, if you see this study which had seen the compared the goal-directed fluid therapy within an enhanced, we had heard about the enhanced recovery protocol, but the patients were for elected colon surgery. Again, goal-directed fluid therapy did not provide clinical benefit in patients undergoing colectomy within a protocol. So the point again comes again and again is that part of restriction, if you are too tight again on the restriction, it is again going to affect your outcome. So goal-directed has to be really goal-directed on determining the patient's needs. Now, how to do that? That's why comes the role of the dynamic measures. Some of us have the opportunity of using them during our perioperative period, some of us those, but these are important gadgets which can give some real-time informations of the changes based upon certain variabilities or the variations. 2 such variabilities are important. One is the stroke volume, SVV, another is the PPV, that is the pulse pressure variation. So once we are able to rectify that and use our fluids based upon those changes, probably we are in a better position to understand the goal-directed therapy on the individual patient's need. Just to give you an overall inspiration, because of the fact is that, as you know, that with inspiration, as the intrathoracic pressure rises, the venous return is impeded, the left ventricular ejection fraction falls, and you can see a small dip in the stroke volume, which during expiration, which again rises. So the venous return increases and the left ventricular ejection fraction increases, the PVR falls. So there is a difference between this SV max and SV minimum. If this range is too wide, it probably suggests this patient is fluid responsive and needs more fluid. You can try a bit more. Same thing, if you have to remember, all this is again validated in that steep part of the Frank-Sterling curve, and once you know that your patient is on that which part of the curve based on these results, it is easier for you to choose your fluid amount and volume. Now, as you go up, you see that there are algorithmic approaches to test this fluid, and based upon the changes on the cardiac index and how much the rise or fall has been based upon, to reassess the SVV, and once you find that those differences has come down to less than 13%, you know that this patient is not going to respond to further fluid, and you have to just give the maintenance therapy. If the patient is still hemodynamically unstable, you have to start with inotropes or vasopressors, whichever you. Whether you should choose SVV or PPV, there are different studies, but most of the studies so far have found no difference in outcome between the two. And for the sake of convenience, you have to remember that both are only validated in mechanically ventilated patients using large tidal volumes. So you cannot extrapolate it in scenarios like ICU, where you have spontaneously breathing patients, or you are using low tidal volume as per the ORDS net. So now, does stroke volume variation predict fluid responsiveness of children? This is again a systemic meta-analysis. There were certain fallacies in this meta-analysis, of course, but they incorporated 6 studies with a total of 279 fluid boluses, and they were heterogeneous, and they could not find too much of difference between the two. But this study, which compared esophageal Doppler-guided goal-directed fluid therapy in major colorectal surgery, they found certain benefits, and the increased perioperative fluid volumes and increased stroke volumes in patients receiving GDT did not translate to a significant difference. But that significant difference which they considered, this study did not have the power to detect. So there was a post hoc analysis of this, which found again a significant difference in between the groups who received late EDT when compared to with early GDT. So the parameters used to guide fluid responsiveness are variable. They include the static parameters, the dynamic parameters and of course, if you have the dynamic parameters, you can assess a better way to assess the fluid responsiveness. So on this ground, it is very important to realize the value of fluid challenge, which aims at identifying patients in whom fluid administration improves hemodynamics. This was published in 2005 initially, and they described the trawl approach, where to determine the type of the fluid, the rate, the objectives, and the limits for safety. A positive fluid channel suggested that a fluid administration should be continued as long as the response to fluid challenge is positive, and the decision to stop fluid administration occurs when a negative response to fluid challenge occurs. The definition of if the fluid challenge lacks standardization, but most commonly involves infusion of crystalloids or colloids. There is absolutely no difference. You are free to whichever you want to, of 500 ml over 20 to 30 minutes, and considering an increase in the cardiac index of more than 15%